Welcome to the EAU podcast. In this edition, UROONCO Kidney Cancer Educational Platform Chief Editor Dr. Carmen Mir talks to Professor Nizar Tannir from University of Texas MD Anderson Cancer Center, USA, on result of the CheckMate 214 trial.
Welcome to our podcast series from UROONCO platform Renal Cell Carcinoma from ASCO GU24 in San Francisco. Today we welcome Professor Nizar Tannir, full professor at the Department of Genitourinary Medical Oncology, Division of Cancer Medicine at University of Texas MD Anderson Cancer Center in Houston. He has done extensive work on deciphering the best treatment for metastatic RCC, either clear cell or non-clear cell. He is a strong pioneer in the field. Welcome, Professor Tannir.
Thank you, Carmen. Thank you for the invitation to be with you and to have that conversation to summarize the results of the phase 3 trial in first-line therapy of patients with advanced clear cell renal cell carcinoma, the CheckMate 214 trial. Now, the CheckMate 214 trial was the first trial launched several years ago in the first-line therapy, and that's the first trial that showed survival advantage for patients treated with Nivolumab plus ipilimumab, what we call or refer to as NIVO+IPI for short, compared to sunitinib, a TKI. The three co-primary endpoints of the CheckMate 214 trial were overall survival, progression-free survival, and objective response rate in patients with intermediate or poor risk as defined by the IMDC criteria. The secondary endpoint is basically the same efficacy endpoints in patients in the overall total population, what we refer to as ITT, or intent to treat patient population. Mm-hmm. There was an exploratory endpoint or objective in patients with favorable risk, again defined by IMDC. So the 8-year follow-up, which, I presented at ASCO GU this year, showed stability of the hazard ratio for overall survival in patients with intermediate risk, poor risk, and in the intent to treat patient population over the last 8 years. So at the first analysis, primary analysis, when we had only 17 months median follow-up for the study, the hazard ratio for OS was around 0.7, if you remember that, 0.7.
That was a while ago. Huh?
A while ago, we actually, Dr. Bernard Escudier from the Institut Gustave Roussy in Paris presented that first analysis at ESMO in Madrid in September 2017. Subsequently, we had other analyses, other updates, 30 months, 42 months, 48 months. And the last one before my presentation at ASCO GU this year was the 60 months or 5 years. And what we have observed over the last 8 years is the hazard ratio for OS has remained stable. And for patients with intermediate risk, poor risk was 0.69. And for patients with the intent to treat patient ITT population was 0.72. That's remarkable, and that basically sets NIVO+IPI as the only regimen that has shown stability of hazard ratio for OS over time compared to other regimens in the first-line setting. There are, in the US, there are 4 regimens that are FDA approved for first-line therapy of patients with advanced clear cell RCC, and these are NIVO+IPI, and then Pembro-Axi, Cabo-Nivo, and then pembrolizumab and lenvatinib. But the other trials they have not shown that stability of the hazard ratio, and they do not have that 8-year follow-up. So this is the first and only trial that we have results to report. We reported with, from CheckMate 214 over 8 years. So that's really the first take-home message, the main, key point of the results from 8 years. The second important take-home message is the progression-free survival for patients with intermediate risk, poor risk, at the initial primary analysis was not statistically significant. It was a co-primary endpoint, as I said, for patients with intermediate risk, poor risk. But at the initial analysis, the hazard ratio was around 1, and now the hazard ratio is 0.73, and the 95% confidence intervals are under 1. Whereas at the primary analysis, the upper bound of the confidence intervals was above 1. So now there is a statistically significant difference for PFS between NIVO+IPI and sunitinib, with median of about 12 months for those patients with intermediate poor risk with NIVO+IPI versus 8 months in patients with sunitinib. And if you look at the Kaplan-Meier curves for PFS over time, and now with 8 months, 8 years median follow-up, 8 years or 90 months, you see that around 25%, quarter of the patients are alive and progression-free with NIVO+IPI. And there is that, if you look at the Kaplan-Meier curves, you'll see a tail or a shoulder tail at the end of the curve. So there is really no relapses at 8 years or 90 months, follow-up.
So this is how you would counsel your patients when you decide about getting them ipi/nivo?
Well, I think, obviously in the US and I'm sure in Europe, NIVO+IPI is approved for patients with intermediate risk, poor risk. In the US, the NCCN guidelines, and of course the Europeans have the, EAU guidelines, and there is ESMO guidelines. So there are different guidelines, classifications, but the NIVO+IPI is approved for intermediate risk, poor risk. For patients with favorable risk, it receives a category 2A in the US by the NCCN guidelines. Now, I think, how do I counsel my patients? Of course, you have to look at the patient's tumor burden, symptomatology, history of comorbid illnesses, if they have any prior history of autoimmune disorder. But if the patient is physiologically adequate, has adequate organ function and physiologically is fit, I do, for most of my patients with intermediate risk, poor risk, and in fact, even in patients with favorable risk, I offer NIVO+IPI because I do believe that the patients at the end wants to be cured. And the way to cure would be to achieve a complete response that's durable. And patients want to stop therapy at some point. And so the trial that gives the best treatment-free survival or treatment-free interval is immune therapy. Okay. Patients who are treated with TKIs and anti-PD-1s, unfortunately, over time, not only do they have the chronic toxicities of the TKI, but there is also relapses over time. And there is really no tail at the end of the curve. Like I said, a quarter of the patients are alive and progression-free with NIVO+IPI. So there is an important point to make when you are thinking about prescribing NIVO+IPI or any therapy for your patients in the first line. Does the regimen have a high progressive disease rate? And that has been a concern raised by some of the proponents of an anti-PD-1 plus TKI compared or versus NIVO+IPI, that the progressive disease rate in patients with treated with NIVO+IPI is somewhere around 20%, which means that if the patient doesn't respond to NIVO+IPI during that induction therapy during the first 12 weeks, when you give both drugs every 3 weeks during that 12-week period, that they may not have a chance to go to a second-line therapy. How I treat my patients, I do not blindly give them the NIVO+IPI and keep giving them every 3 weeks the treatment without really closely monitoring how they're responding to therapy and not doing scans till 12 weeks. I think doing scans anytime is appropriate, and you don't have to wait 12 weeks to give all 4 cycles of NIVO+IPI and then find out later after the 12 weeks they didn't respond, and then they miss a chance of going to a second line. I treat them and I repeat their scans 6 weeks later after the 2 cycles if they have progressive disease, especially if they had symptoms at initiation of therapy and they continue to have that symptomatology, they have not improved, then I quickly change to second line. I have not had a patient who did not respond or had progressive disease through first-line therapy with NIVO+IPI not get a chance to take a second-line regimen. So that concept of you have only one shot at goal doesn't apply to me and my patients, because I give them multiple chances at the goal post. If you talk about soccer and having a shootout.
You have a chance. How about the patients with sarcomatoid features? How would it work for this subgroup?
Well, I think there is clear consensus. There is a consensus among all the experts in renal cell carcinoma that if there is a group of patients that are best treated with NIVO+IPI as first-line therapy, it's those patients who have clear cell RCC and have sarcomatoid features in their tumor. Because we published this in Clinical Cancer Research in 2021 and in JITC, Journal for Immunotherapy of Cancer, in 2022, where patients who had sarcomatoid dedifferentiation and their tumors had a 23% complete response rate and a median overall survival of 4 years compared to sunitinib. Median survival has not changed over years. If a patient has sarcomatoid histological features, and the median OS for those patients with sunitinib was 13 months. There is no other regimen for patients with sarcomatoid dedifferentiation that produces the 23% CR rate. And if their tumor is PD-L1 positive, the CR rate is 25%. And there is a tail at the end of the curve for those patients. About half the patients are, progression-free, alive and progression-free, treated with NIVO+IPI. So this is a very aggressive clear cell RCC histology that we have transformed to a potentially curable, and I've had several of those patients who are alive and well, several years haven't been treated with NIVO+IPI, and they have not required second-line therapy and have not had the recurrence after being treated with even just a few cycles of NIVO+IPI. If they develop toxicity and we had to stop the treatment because of immune-mediated adverse events, they never had to be treated with anything else, and they remain alive and progression-free and in remission. So if there is a take-home message here also is that for patients with sarcomatoid dedifferentiation, which is about 10 to 15% of patients with advanced clear cell RCC, about 10 to 15% will have that. That should be, I think there's a consensus to give those patients not an IO-TKI, but an NIVO+IPI.
Well, thank you so much for sharing your knowledge with us. We learned a lot about first line, what's coming, and we'll keep you tuned. Thank you.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with kidney cancer developments, visit our educational platform UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.